Hi, I'm Cassie, and today I'm going to be your preceptor. Welcome back to the channel. It's Cass. Today we are going to be discussing giving report. I know it can be scary, but we are going to tackle it together. We're going to discuss all of the things that will make you nervous about it. But before we get started, if this is your first time here, please take one moment to tippity tap the bell. Give me a thumbs up. Don't forget to like, comment, subscribe, and share. And also make sure you turn your post notifications on because we are doing this series, guys. Like, we are getting to the bottom of this. I want this to be a resource for the people, by the people. Like, we just have to keep this going. Like I said, today we're going to be discussing giving report, which I know can be scary, especially if you're a new grad. Even as a traveler, I still get nervous because you just don't know what kind of temperament you're going to deal with. I've been seeing a lot of hilarious videos on TikToks about like giving report to people who ask the most unnecessary questions, and that can be nerve-wracking, especially when you're new. Now that I'm a little bit more seasoned, I don't be taking it, you know what I'm saying? And that is just something that you build with confidence. And I will politely tell somebody like, are you planning on checking the chart today? Because here's the thing about report. I can give you the best report ever, and it could all be wrong information. You know what I'm saying? So I take everything that anybody says with a grain of salt because I personally will be going into the chart myself and reading those notes. Like, you have to do that. You have to take some time. Even if you're really busy starting off at 6, that's still something you should plan to make time for in your shift at some point in time, because that's the only way you're really going to 100% know what's going on with your patient, as well as talking to them and seeing them and, you know, assessing them yourself. So you need to assess your patient and you need to assess your chart. Like, those two things are non-negotiable, and I feel like a lot of people try to skip the step of assessing your chart because you may be busy, but you have to find some time, even if it's 1 second, just to be like, okay, I want to know what their exact history is, because the history in the H&P is 100%, like, that's the doctor to the patient. Anybody can input history within a chart. Like, you can just update it whenever you want. So even looking through there, that could not be 100% accurate. So yeah, let's just jump right in. Okay guys, so first things first, let's get our report sheet together. Like, that is number one. There are so many cool report sheets. The report sheet that I used at my first job was so perfect, and I don't understand why everybody doesn't really follow this motto. We had a report sheet that you could just grab from the desk as soon as you got a new admission. It was a generic page. It had all the information that you needed, and this was a piece of paper that got passed along. Like, you continue to pass the sheet along. That was the first and only hospital I've seen do that. I don't understand why we don't continue that practice. I think it's very important to have a report paper that is started by the person who did the admission, and then you continue updating that paper, that same paper. Of course, sometimes it can get overwhelming. If someone has been there for forever, we would just like either start a new one or staple a new one to the front and keep adding on the information. But passing on report sheets, we need to bring that back. We need to bring that back immediately. If you work at a facility that doesn't pass along report sheets and you're on your own, this is where you kind of have to get creative. And this is what has prompted my many report sheets that I've done. I found a method that really works for me. If you have not seen, and you're gonna probably hear me reference this video multiple times throughout this series, if you have not seen my original epic assessment sheet, like my nurse survival guide, I highly suggest you watch that. It's very detailed, and it really gives you an overview of what I do with my assessment sheets and just like my overall plan for nursing and like what I do when I get to the hospital. So I think you should start there. If you see that sheet, you'll see exactly how I set up my epic, and my patient list is perfection, okay? She really says it all, and I'll tell you guys a few things that I look for with my assessment sheet, because this is something that I print out, and this helps take off half of your report. This is how you do it, guys, okay? Like, Even if you have to hand write this stuff, I think this is some of the most important stuff, and this is what I start my report off with, and then I move forward with more information. So of course you want to have the room. I have the patient's name, I have the age and gender, I have the admission date, which is so important. I have the admission diagnosis, again, super important. If they're there for a surgical procedure, I have the admission procedure as well. I have their diet, their attending physician, that helps to know if they're a hospitalist or if it's a surgeon that you have to contact. Their code status, you already know, 100% have to know that. Their allergies, super important. If they're on isolation, why they're on isolation. And then if they are on tele. Those are the basis of report. Like, if you don't know nothing else, you gotta have this information down. You get what I'm saying? And I find it so helpful that with Epic, I'm able to set up my patient list that way. And so I'm able to print out my patient list that way. And that right there, like, I literally read that part off for my report. If you remember in the previous video, I discussed folding my patient list hot dog style and then including the sticky notes. Today we're going to talk about what I include on the sticky notes. And again, once I finish reading off that patient list part, like, I literally will start reporting like, all right, this is the patient in room so-and-so. Patient's name is, they are a female, male, they came in on, the admission diagnosis is, this is the procedure that they've had, this is their diet, this is who their attending is, they're a full code, they're allergic to latex, they are on contact for MRSA, and they are on tele. Boop, right there. Like, you already gave them everything they need to know. Now, of course, you have to say some more, so we're gonna go a little deeper. So I start off by writing these 3 things on my sticky note because honestly, when I'm getting report, I'm not really listening to what the person is saying because of course they're starting off with like, this is the patient's name, this is their age, this is, you know, their code status. I already know all of that because I literally I read along with it on my patient list. I already read my patient list, and as we're walking up to the room, I'm already reading my patient list again, so I already know what room, how old they are, their gender, their status, allergies. Like, I have all of that literally printed in front of me, so that knocks off a lot of work. From there is when I actually go in with my sticky note, and I'm gonna start off by I'm listening for you to, as soon as you say this is what they're here for, that's when I start writing. The first 3 things that I do is literally I'll write diagnosis, history, and plan. Those are what I want to hear. I want to hear those things specifically. I'm gonna go back and read the chart anyways, but if I can just get like this little mini clip on top of what I already have for my patient list, then I am halfway there. So once I find out what the diagnosis is, let's just say that the person came in for a right femur fracture. Once I hear right femur fracture, the next thing I'm waiting to hear is whether the person had surgery or not. That is, I immediately want to know that. So let's just say that they had surgery. If they were admitted on 5/20, they had surgery on 5/21, and they had an IM nailing. And I want to know if the dressing is right then and there. Some people have 2 to 3 spots, 1 spot. Like, these are things that I want to know. I need to know this kind of information. Am I going to go in and see it myself? Yes. But also having this written down and having like a good quick report sheet, this helps you in the morning. So if you can like kind of get your report sheet already set up during report, you're good to go. That knocks off a lot of time, and that gives you the time that you would have spent, you know, trying to like figure out what to write down for a report. You can use that time to actually go into the chart and read up on the chart and then add in anything else that you feel is going to help report and something that you want to tell the nurse. So 5/21, they had an IM nailing, they have an aquacell dressing. And that helps me know, because if I hear aquacell dressing, I'm already assuming you're not getting a dressing change. That's not something that I'm looking for unless the patient has pulled off that dressing. Because if you know, or if you don't know, an aquacell dressing lasts for 7 to 14 days. You can shower with it. So most people who have aquacell dressings post-op, they're going to leave with it, and then they will get it taken off at their follow-up appointment outpatient. Now, if it's something like a dry dressing with maybe some ABD pads and like, you know, Curlex and all that stuff, when I hear dry dressing, ABD pad, I'm thinking, okay, that's something that could come off. It definitely is, especially if you're like staying in the bed long term. So I'm already thinking in my head, make sure you grab some dressing supplies, if necessary, at least 1 or 2 ABDs, just in case you have to change the dressing, because again, those dressings don't last as long as the aquacell dressing. My concern is just making sure that those dressings remain closed and that the patient doesn't have any risk for infection. So from there, I'm usually looking out for the history. Let's just say, you know, they have had a ground level fall before, so they're a frequent faller. I'm already Is the bed alarm on? Yeah, let's make sure, because I don't have time for that. Hypertension. I'm also looking for anything blood pressure related, because you have to understand that you're with a patient, any surgery patient or any patient that is there for anything. Honestly, I'm always concerned about pain and making sure that their pain is being managed well. Some people don't need pain medication every 4 hours. Some people could take one narcotic at night. They take their Percocet with their nighttime meds and they are good to go until the morning time. Some people do need their things Q4, and that's something that I'm going to be thinking about. I'm gonna check the MAR myself and see how you're trending with medication. Are you someone that's getting something Q4? Are you someone that's only getting something once a shift? Because then that's something that I'm gonna discuss with you as part of your plan of care, because some people don't, again, want a whole bunch of medication, and some people wanna stay on top of it because the pain is excruciating. Like, they just had surgery. So all of these things are things that I'm thinking about while I'm getting report. If your blood pressure is bottoming out, that's something that I'm concerned about. And so if you don't have like CHF or anything, I'm gonna call the doctor and be like, hey, I've noticed that the pain medication is kind of decreasing their blood pressure. Can we get them back on fluids? Or I'm just, encouraging my patient to drink more fluids. Because here's the thing, if your blood pressure is anything below 110 systolically, I am not giving you that pain pill. You can get a Tylenol, but you want that Percocet? You want that Norco? We got to keep that blood pressure up, because it affects so many things. And I always tell my patients this. These are things that I actually tell my patients, like, hey, I've noticed your blood pressure is starting to trend down. I've noticed that you are getting your medication Q4, and this is something that you want to stay on top of. But we need to have a conversation about this blood pressure, because if your blood pressure is starting to get too low, that affects everything. We're also discussing the fact that we're giving you a narcotic can decrease your respiratory effect. So, and this is somebody, again, I work nights, so you're going to sleep. I had to factor in a lot of those things. And so I love to tell my patients, like, hey, this is what I'm seeing, but these are the side effects of your blood pressure getting too low, i.e. you could have some dizziness, which could affect you working with PT in the morning, which will delay your discharge. And people be trying to go home, like, okay, I got my hip done, when can I discharge? But you're not discharging with that low blood pressure. If that doctor sees that blood pressure too low, and I also will tell my patients this, if your blood pressure is too low and the doctor sees this and they know it's because of the pain medication, some doctors will come up behind you and discontinue those meds. Discontinue them. And then really it's just you and the Tylenol against the world, and some people need something more. So I love to tell my patients that, like, this is how we're gonna remedy it. Let's work on your fluids. Let's increase your drinking. Let's maybe try to space out the medication if we can. These are all things that I talk to my patients about. And so they're not confused when I just say, like when they call and they're like, hey, can I get my pain medication? And I'm just like, no. They know exactly why I'm saying no, because I go to their room and I'm like, hey girl, your blood pressure is 90/58. I'm not gonna lie, sister, the Percocet's not happening. It's not happening. And 9 times out of 10, I'm not gonna lie, most of my patients, as long as I communicate it to them, they're like, you know what, you're right, girl. Definitely don't want my blood pressure to bottom out anymore. Don't want to be dizzy, and I want to go home. So you just let me know how you think, like, how should we handle this? And we go from there. So I'll get you an ice pack. Now we have to do maybe some non-pharmacological interventions, and that is just what you should be thinking about. And this is all during report, okay? So again, hypertension, sorry guys, but these are the, critical thinking that you should be thinking when you're getting report. Hypertension, let's say they have hyperlipidemia, they're diabetic, so I'm already like, are you ACHS? You know what I mean? Sometimes you'll have patients that they'll put diabetic in their history because they did a full workup on them when they came in through the ER or when they came in for surgery and their sugar was high. And some people may be pre-diabetic and didn't know. So then sometimes you'll be like, oh yeah, the patient has diabetes, and the patient will be like, no girl, I don't. And it's like, okay, but they had to start you on insulin, and this is like a new finding. So these are things that you also want to know, because some people are going to tell you straight up, I'm not taking insulin because I've never taken insulin. And if their sugar is high, this is where, again, you have to step in and educate. And the thing is about whether your patient is there for surgery or not, 9 times out of 10, their sugar is going to be high, because stress is also a factor in high blood sugar. especially when you talk about surgery, stress to your body, and then any stress physically can also elevate someone's sugar, as well as maybe if you have a respiratory patient that's there for the first time, COPD, asthma, if they're on some type of steroid, that could also increase their sugar, and they may be on insulin just for that reason alone, just because they're getting steroids. So again, sometimes you have to continue to educate your patient, and you have to be thinking about those things too. If they're diabetic, I just go ahead and pop up my ACHS at the top, because that helps me remind the tech. So again, if you don't have time to go through the chart, you could be starting off at 6, you could be starting off at 5, getting an admission as soon as you get to work. Someone's calling you for pain medication that's on the floor. So many different scenarios. And so anytime I can like write down anything that's going to help me remember, I'm going to. So writing ACHS in red at the top, that way I can go back after report, find my tech and be like, hey girl, not sure if they told you, or guy, hey, I'm not sure if they told you, but these are my patients that have to get sugar checks tonight. That way everyone's on the same page, and it's not now 10 a.m., 10 p.m., and my sugars have not been done. Also, that's the time, sometimes you'll find out like, oh, hey girl, I don't do sugars, because some people haven't tested out for it. Maybe their thing has expired. Like, this is the time to get all that sorted out, because again, I don't want to wait until 10 p.m. or if your day shift 10 a.m. and I'm looking around for my sugar and it's like, it's not there. So I like to get all that stuff out of the way, because again, time saver. And then this is also a good time where I will put in their skin. Because again, some people come in for surgery, the only issue that they have is that their skin, they just have that surgical incision, but some people have the surgical incision plus, you know, maybe some bruising because they fell. So I've had patients that have like bruising to the eye, forehead, because again, if you're falling, it's inevitable. You're gonna have some bruising. And then also if the patient is older, they may have like looser skin. So you wanna be able to think about that too, because we are using a lot of adhesives to like hold their IVs together. And when someone has delicate skin, you wanna be really careful about how you're treating their skin. So making sure it's moisturized, making sure you're not using too much tape that is going to tug and pull at the skin, because skin tears on older patients, it's so easy. It happens so fast. And that is something that you have to avoid. Like, I don't want to, now I have to put that in the flow sheet. Now we're getting dinged for like a new skin tear. And you also want to keep your patients safe. Like, I don't want to tear your skin. I would be sick if that happened to me. So like, I'm really careful about what kind of tape, how much tape I use. If you have any male patients and they're really hairy, I don't like to put a whole bunch of tape on them either, because it has to come off eventually and that's going to hurt. So I'm thinking about that. But let's just say they have bruising that's generalized. And maybe they have a skin tear from the fall too. We'll just say to the right elbow. Okay, now from here, this is a surgery patient, so this is how I'm always thinking the plan. They're either going home or they're going to rehab. If they're older, I'm already assuming that they're going to rehab, because 9 times out of 10, you're not doing 100% with PT. And if you don't do really well with PT, you're going to rehab. So I'm always trying to figure that out, because if the patient is going to rehab, another thing you need to be thinking about is that last bowel movement, which this is the time that I don't like to interject when people are doing report, but like, if I don't hear something, I'll kind of wait till the end, or I like respectfully like, hey girl, like, now that you're mentioning like they're going to rehab, have they had a bowel movement? Like, those are the questions that you should be thinking about. So let's say that they haven't had a BM yet. Maybe their last BM was when they came into the hospital. So we'll just say last BM was on 5/19. So if they have not had a bowel movement post-op and they're going to rehab, or even if they're not, you want to make sure that you're thinking about a bowel movement. It's so important, because with narcotics, again, this is all circling back to meds. One of the side effects of narcotics is constipation. So you kind of have to work with those meds together. Obviously, your pain is excruciating. You have to have that treated. But if it's going to stop you up and back you up, I also want to make sure, does this person have Colace ordered? Do they have maybe a Miralax PRN? Maybe they have a suppository. If it's been a certain amount of days, you want to make sure that you're getting that stuff into your patient, so that not only is their pain being treated, but they're not going to have any type of constipation, because a patient that gets too constipated, that can lead to a small bowel obstruction or any new GI issues. Now that's a whole new consult, and that is not something that anybody should have to deal with. So making sure that your patient has had a bowel movement is so important. So the plan is for them to go to rehab. They have worked with PT, but they were only able to do they were only able to stand at the side of the bed. So when I hear something like that, I also want to know what's going on with physical therapy. Is it somebody that I can help get up to the restroom by myself? Are they a 2 assist, 1 assist? Are they bed bound? Do I need to just be thinking about bedpans? If I'm thinking about bedpans, then I need to be thinking about their skin again, because some people will not call you to take them off that bedpan because they're trying to go so bad. But if I put someone on a bedpan, the most I'm gonna give you is 5 minutes. I'm gonna come check on you. And if you say you still haven't gone, I'll give you another 5, but I'm gonna readjust the pan so that way you know you're not sitting in the same exact spot. I'm gonna readjust that pan, come back in another 5, then after that I'm taking it off. I always let my patients know, like, we are here to help you. If you have an accident in the bed, don't be ashamed. We have Chuck's pads down, we'll clean you up. This is what we're here for. Like, I don't want your skin to break down because you're desperately trying to have a bowel movement and you want to sit on this bedpan for an hour. It's not gonna happen. Everybody's skin, again, is so delicate, and that sacral bone, no ma'am, I'm not doing it. Some of my patients really try to fight me on this, like, girl, just please leave me on the bedpan. No. If you want to call me again in another 15, 20, and I'll tell my patients, because we have to be reasonable. Obviously, you can't keep calling like every 5 minutes for a bedpan. I'm in another patient's room. I may not get there in time. So like, these are just scenarios that can happen. But I'll tell my patients, like, okay, we weren't successful this time. If you happen to have a bowel movement in the bed, we're gonna get you cleaned up. We're here to help you. But if you want to try to use the bedpan again, let's give your bottom like a 30-minute break. Call me again in 30 minutes. We'll come back. We'll put you back on the bedpan. But we got to give your skin a break. So these are things to just be thinking about. So if you're going to use this method to give report, this is definitely something that you want to do with your little sticky note or your paper. If you're trying to be quick and you know you're going to go back later and read a little bit more. Diagnosis, history, plan. If you have those 3 things, you're good to go, along with the patient list information that I listed before. If I did not have my patient list, which when I have Cerner, I don't, I make sure I write down that person's room number, name, age, admission date, diagnosis. Like, these are things that I continuously keep going. And that's what is on my actual report paper if you want to use it. So I have a blank one, and those are the things that I'll fill in. That way you can also just read along straight there if you want to, because when I give report, I literally read across this line, and then I unfold my hot dog style paper, go to my sticky note, and I give them the diagnosis in depth, as well as the history and the plan.